Good morning. Thank you for coming. The subject of our discussion today is strep throat bacteria, rheumatic fever, Sydenham's chorea, and PANDAS and the PANDAS disease model, strategies to heal our children. And Dr. Madeline Cunningham, who's from the University of Oklahoma, will be speaking to us as a microbiologist, infectious disease and immunologist, expert on strep throat bacteria. She'll be explaining to us the evolution of this illness and the autoimmune aspects of it. In the meeting today, there'll be three mothers, one from the United States and two from Sweden, who will be discussing how the disease model of PANDAS and Sydenham chorea is exploding worldwide and evolving, we believe, in our families' lives. So as brief background as to the science of PANDAS, I'm going to go to my next slide and explain that Columbia University and Stanford University, too, is very concerned about the nature of strep throat and how it's evolving in our patient population. So we created a small genetic repository. Currently, we have 209 people in the repository at Columbia. And we're seeing in terms of autoimmunity that in the families that we've questioned, first and second degree families have a strong autoimmune component, 1 to 2 autoimmune diseases often per family. So rheumatoid arthritis in 38% of the families, hypothyroid in 38% of the families, irritable bowel syndrome or Crohn's disease in 28% of the families, psoriasis in another almost 30% of the families. And in the beautiful Swedish cohort that we met with in Sweden, 46 of the families, there's 26 people that we had in the cohort, have Ehlers-Danlos. So then the other background, I want to just refresh everybody's memory that PANDAS and PANS connote an acute sudden onset with children. This is an evolving diagnostic, criteria, we think, because what we're seeing increasingly is that children are having a gradual onset, but doctors who are learning about disease often are strict about using this abrupt onset criteria, and we're going to discuss how that maybe needs to evolve into a more gradual onset. Also, just keep in mind, parents who are listening to this, that PANDAS has neurologic symptoms like deterioration in school, inability to hold a pencil, sensory and motor abnormalities, other types of somatic symptoms. And also in Sydenham chorea, which is an older diagnosis that's been around for, I don't know, at least 80 years. The presence of a strep throat bacteria could have happened weeks before the onset. The symptoms are often gradual and mounting over time. And you'll see too that gait, fatigue, swallowing issues, which is something we don't talk enough about in PANDAS. Tics is maybe what we talk more about in PANDAS, and trouble focusing and writing. It's very similar, and we're thinking that perhaps we need to evolve the PANDAS diagnosis, or maybe get rid of it altogether, honestly. So the first presenter today will be Amy Abrahams, who thankfully contacted me. And just introduce yourself and tell us your story, please.
Thank you so much, Diana. My name is Amy Abrahams. I'm from Chicago, Illinois, and I'm going to start our family story at the end. My daughter, Sophia, is 19 years old now. She is a sophomore in college. She's a straight A student. She is healthy, she is strong, and she is beautiful. Having said that, in 2019, our story looked very different. And as a matter of fact, at that time, we weren't even sure that our daughter would see the inside of a high school. To take you back to the beginning, we took our then 12-year-old daughter for her physical at the start of summer break. And the doctor looked at us and said that she had lost 10 pounds year over year and had not grown even a millimeter. Unfortunately, seeing her every day, I didn't notice the weight loss. After many vials of blood came back normal, none of which included a test for strep titers, our pediatrician looked my daughter in the eyes and told her straight up, "You have an eating disorder." My daughter, who had just completed the eating disorder unit in 6th grade, looked right back at her and said, "I do not have an eating disorder. I don't want to be thin. I don't think I'm fat, and I'm not purposefully withholding food." What I did not know was that my 11-year-old child was basically not eating breakfast or lunch, meals that were unsupervised as both of her parents worked full time. She was eating a normal dinner nightly, and we ate with her every night, so that's what we saw. The words, "you have an eating disorder," changed everything on a dime. Once my daughter heard those words, that was it. She stopped eating dinner as well. Essentially, no food was going in, and things spiraled out of control fast. A few days later, we had no choice but to admit her to a behavioral health facility, at which point she was at a 1% BMI and on the verge of organ failure. 2 days into her stay, they diagnosed her with ARFID, avoidant restricted food intake disorder. It was explained to me that there are two types of ARFID: the picky eaters who've just been that way their whole life, and the restrictions get intense, so they lose weight. That's the majority of kids. And then the small bucket are the kids who just lose the desire to eat, which is the bucket they put our daughter in. They did not release my daughter for 22 days. So if you're counting the drama of a misdiagnosis, that's 22 days of being supervised when she was in the shower, when she went to the bathroom, not being allowed to wear shoes with laces or drawstring pants, and 22 days of seeing her family for no more than 2 hours a week. In terms of what I was doing during those 22 days, I was reading everything I could on how to solve ARFID. I joined the ARFID Parents Facebook group where there were some scattered mentions of PANDAS. It was enough that I asked every doctor, nurse, psychiatrist, psychologist, eating disorder specialist, anyone that had come in contact with my daughter, if they thought she had PANDAS and not ARFID. And they all said no, multiple times. And this is despite the fact that now, in addition to challenges with eating, she was exhibiting OCD. I didn't push because at the time when I Googled PANDAS, eating restriction didn't show up. And I just believed the medical professionals. After 8 pounds were added to my daughter, they sent her home and said it was over, and they sure seemed right. She was perfect for about 10 days, even gaining 3 more pounds at home, and we fully thought this was over until it wasn't. The whole thing started over with a vengeance. I told my daughter that I needed her to help me so that I could help her stay out of the hospital. And my daughter point blank looked at me and said, "I will not help you." I knew we were in deep trouble. I wasn't going to send her back to the behavioral health hospital. They obviously hadn't fixed anything. I found a therapist that specialized in ARFID and a pediatric weight management specialist. My daughter's behavior now included food refusal, OCD, severe depression, separation anxiety, and she started saying the craziest things. About 3 weeks into the nightmare, the veil lifted, and we literally thought, that therapist is a miracle worker, until the entire thing started over again a few weeks later. At the end of round 3 of this mess, it was time to go back to school. A few weeks into school, round 4 started. I received a call from the school psychologist sharing an essay that my beautiful daughter had written in English class, where she said had she known that she would only be happy and a normal person through 5th grade, she would have appreciated her life more. I was beside myself. I called the pediatric weight management specialist, and she immediately put her on antidepressants. We saw no change. Again, I revisited PANDAS, but this time I Googled PANDAS in conjunction with eating restriction in my browser, and my screen blew up. I knew right at that moment that my daughter had been misdiagnosed. I was also finally putting the pieces together that each time she went down the rabbit hole, it was accompanied by an illness. She would stop eating about 3 days before exhibiting the symptoms of whatever she had, a fever, a cold, etc., and we would be in hell for about 3 weeks. We were fortunate to get her in with a PANDAS specialist in our area within a day. They heard out the details of her story and took the time to learn that I, her mother, have 2 autoimmune diseases, including hypothyroidism and vitiligo, and said that in all likelihood, Sophia had PANDAS. They drew lots of blood, but this time they included strep titers. They weren't off the charts, but they were about double the acceptable amount. Within 3 days on antibiotics, my happy, normal daughter returned and ate like a normal 12-year-old. 3 days. The bottom line was that every time my daughter was getting sick, she went into a PANDAS flare. It was most apparent during COVID when everyone wore masks and my daughter didn't get sick for 18 months. She was PANDAS free the entire time. As soon as the masks came off, the flares started again. The trigger for a flare could not have been more clear. We learned to manage her flares with antibiotics, and we didn't wait. The second she got that glaze in her eyes and we saw her eating habits change, we started the antibiotics. We always got her back to baseline within about 3 days. It is shocking to me that after sharing all this evidence with her pediatrician, she informed me that I needed to accept that my daughter had an eating disorder. I told her that she needed to accept that she had just lost a patient. It is also shocking to me that I was helping another mother just this past February, so 7 years after my daughter's story, and she ran into the same ignorance from her pediatrician, from Lurie's Children's Hospital, the premier children's facility in Chicago, and Compass Health. I sent her to our PANDAS doctor, and they got the car turned around in about 2 weeks. The ignorance about this disease continues with the very doctors we've entrusted to save the lives of our children. I also want to point out that many of the things we read about PANDAS suggested at the time that it's an overnight change in your child. And I'm happy to hear what Diana's opening on this, that that's being relooked at. You don't lose 10 pounds overnight. You don't stop growing overnight. It takes time. My daughter presented initially with only one symptom, the eating restriction. My hope is that we can update the narrative on that overnight change so that children who present like mine will have an easier time getting a proper diagnosis, and that every child who has had strep turn their lives upside down gets the happy ending that my family has. Thank you for listening.
Thank you very much, Amy. I think many of us can relate to what you shared. And I wanted to just clarify that there isn't an academic effort to change the narrative. Doctors are discussing it, and we're going to have to keep pushing that regarding eating restriction and the abrupt onset. But the doctors are open to it, including Dr. Cunningham today. So thank you, Amy, for sharing that really tough story. Don't leave. Stay right there. Put yourself on mute, though. Somebody just said they can really relate to your story, and they thanked you for it. So next is my beautiful friend from Sweden, Stina Lera. She'll be presenting about her wonderful daughter, who's doing quite well now, thank goodness, in Sweden. And we look forward to your expertise and experience, Stina. She also has very important video for American families to see. I'll just say quickly, we're seeing more physical, neurologic, large movement chorea in the United States. We're doing this video, thank you, Stina and Ulrika, of your daughters, because American doctors are not understanding what chorea movements are. So thank you, Stina.
Thank you.
The famous
Can you see my screen now?
Yes, I can. You're vaccinated person.
Perfect.
On the globe.
Okay. So then I will start. My name is Stina Lera, and I'm from Sweden, the south of Sweden, close to Copenhagen. I'm a mother of 3 children, and I would also like to share our story. My daughter is now 13 years old, and she fell ill when she was 10 years old, and she has Sydenham's Chorea.
I think this might be your screen of the vaccine lady. It's not.
Oh, sorry, I'm using the wrong screen. Sorry. I'll do it again.
But she's very adorable.
No, that's not very nice.
Whoever she is.
Sorry. I was waiting when you were talking, so we'll just stop again. See.
It's okay. This is our first webinar, so we're having.
Now you see the right one.
Learning.
Right? Sorry
okay,
about
thank
that.
you.
Okay.
Go ahead.
So I'll just give you a short introduction before I tell you a little bit more about my family and our story. Very briefly, in Sweden, in 2022, Sweden, as many other countries in Europe, reported increased rates of invasive group A strep. And we did also have a lot of scarlet fever. Sweden are very proud of that we have the lowest level of antibiotics. And it's quite difficult actually to get antibiotics in Sweden at the moment. The healthcare is a bit different from the US. It's publicly funded and need-based, which is really good in many ways. But it also means that all children are treated exclusively within the public system. And this means that an accurate diagnosis is, of course, the most important thing all over the world to get effective medical care. But in Sweden, it gets really important because if you get the wrong diagnosis, you have nowhere else to turn. I will now share a video of my daughter. It's kind of like a timeline where you can see and follow. It's 1.5 minutes, and after that, I'm going to take you through our timeline. So this is what we have gone through for a few years. It all started in the autumn of 2022. I have 3 children, and 2 of my children was home from school with a fever and a sore throat. It lasted for about a week. After that, they went back to school. Everything was fine. But about approximately a month later, something happened to my daughter. It was a sudden onset. We didn't recognize her. She got a fever back. She was really cold. She was acting really strange, and I asked her, like, what's wrong? And she couldn't tell me. She couldn't explain what was wrong with her. She was really fatigued. She had a fever. She had chest pains, body ache, sore throat, and she stopped eating and drinking, like really abrupt. It was really strange. She wouldn't even drink water. So we had a lot of problems. In just about 3 weeks, my story is quite similar actually to Amy's story. She wouldn't even take any water. I called the hospital, of course, right away before all this happened. They said no. I went to the emergency room and they didn't want to see us. So after a while, the only thing I had to do was to call the psychiatric unit. By the time we got there, she was so ill, so they couldn't measure her blood pressure or her pulse. It was 37, her pulse. So they told us that we couldn't even wait. They said, you have to go directly into hospital. So we had no choice then because we were afraid she was going to die in our house. So what we did is that we actually signed a paper and we got her admitted to the psychiatric unit for involuntary care. And since she wasn't eating, the diagnosis she got was anorexia. And we were sure she didn't have anorexia. She had never had any problem with food intake. She had never had any psychological problems. We mentioned PANDAS, but the doctor said, no, that can't be. It doesn't have anything to do with eating disorders. She was in the hospital for about 6 months in total, I think, a very long time. No treatment worked. And we were commenting to the doctors that, like, can you not see that this is not working? So after that, they did change it and were considering FND and other things. They did not test her for anything. I asked for a strep test. In 2023, about 6 months later, I finally got a strep test done. And they said, like, there you go. You can have your strep test. And they took it. And of course, she had strep. She was positive. She got some antibiotics. She started to eat. But then it stopped after just 10 days, and then she didn't have any more antibiotics, and it all came back. A month later, she had rheumatic fever, and then the story is then Sydenham's Chorea. I will hurry up now because I don't have so much time. So we did we didn't get any help in the Swedish system, so we decided to go abroad. So we went to Dr. Ubi in London, and then we flew to Dr. Latimer in Washington, US. And we also visited a specialist in Sweden called the Gillberg Center, and they all said, this is Sydenham's Chorea. So after this, we did remove her tonsils after recommendation from Dr. Harley in Washington, and we were fighting to get treatment for her. It did take a lot of time, but finally we did get some treatment. In 2024, we did a long run of IVIG. It did work, but it didn't work all the way. The things that have worked for us is actually rituximab. She's today healthy and well. Well, I will really speed up now then. So for 2025, we continued, and she had a big recovery. She was in a wheelchair for 2 years. So it was a recovery from getting muscle strength back. She's been on Ritux for about a year now. She had returned to school. She's back in a normal class. She's back to being a straight A student. She lives an active life today. What I want to, the message I want to send to you is like the misdiagnosis is really crucial, because if you have a misdiagnosis, you don't get the right treatment. The loss of mobility and independency was really difficult for her. And I do feel for all of you, if you are in this situation at the moment, that family, work, and social life, it's very, very difficult, but it will be easier times. So my key outcomes from this is to get an accurate diagnosis, to make sure you get the right treatment, and of course then work with the recovery. And you have to be strong parents in order to get all this together. I also want to mention that we did the autoimmune brain panel, the Cunningham PANDAS, which is Madeline is going to talk about a bit. And I think this for me was very good, because it gave me, this was after 1 year of IVIG, and she still had really elevated antibodies, but it did give me answers to why my daughter was behaving the way she did. And after that, it was really easy to get treatment and see the changes, and she slowly came back to the girl she was. And I was to end with this picture, which is from last week when we went on holiday. And I now have 3 healthy kids. They're all good. They play together. Her brothers have got her sister back, and it was a difficult time for the whole family. Thank you.
Thank you so much, Stina. That was a very moving and shocking video, and thank you for allowing us to see her heal over time. She's also, I have to just say, as with Ulrika's daughter and Amy's daughter, but Stina's daughter is very good at art, and so that strange clock, the squiggly clock drawing is no more. She's doing pencil drawings and beautiful portraits. So all the beautiful story of PANDAS / Sydenham, Chorea is kids can heal.
So they will get healed. And I think that's an important part as well I would like to mention, maybe for rehabilitation, is really not to push. I felt really guilty not having my daughter in school. By law, she has to be in school, but you can't. She was out of school for 3 years, but she's still back doing great. But we did a lot of creative activities when her muscle strength came back. And I think there's so many things you can do, like you said, mentioned painting, crochet, doing all kinds of things to making the children feel a little bit better. And don't push them too hard to go back to school and do all these things. Those things would solve.
They have to be a grown up and pay their bills later. Right, exactly. So thank you, Stina. We could talk on and on about all of these cases, but I'm going to go to Ulrika. And I'll just say, since I know there's so many parents listening and I have so many things that I want to say, is that after this conference or this meeting where we're learning about the science of this terrible onset, we're going to have other webinars where mothers and fathers can talk more about strategies, and we'll learn from you, Stina and Amy and Ulrika.
We could talk for hours, so it's difficult to keep it short.
All right, so thank you so much. And now you're going to present slides for Ulrika Grahnat, my dear friend. Thank you, Ulrika.
Thank you for having me. I'm here to present to you the story of our daughter, who is now diagnosed with rheumatic fever and Sydenham's Chorea. But the way to a proper diagnosis and treatment was very long. We are going to start with watching a video so you can see for yourself her symptoms of Chorea. So I'm going to share with you the timeline of her journey from start to recovery. So it started in 2020 when she had a throat infection, and we took her.
Sorry, remind us her beginning age, please.
Oh, sorry, yeah, she was 7 at the time, and she's 13 at the moment. So at 7, she had started school a year and a few months prior, and she was a perfectly healthy child, no problems whatsoever. And she had a throat infection, and we took her to the doctors. They did see that she had a throat infection. She had a high temperature, but they did not perform a throat swab, and they did not treat her with antibiotics. 4 weeks later, one night, the 30th of November at 7 p.m., she had a sudden onset of Chorea. Her one hand started moving, and after a while, her whole body was moving uncontrollably. And we obviously took her to the hospital, and they initially did suspect Sydenham's Chorea, but the pediatric neurologist had only seen one case at one point in their career. And when she later on started, the Chorea movements changed a bit, and she also started having separation anxiety and other neuropsychiatric symptoms. They just attributed her symptoms to functional neurological disorder. And this was despite the fact that she actually had a temperature and she had elevated inflammation markers. Her condition progressively got worse when we were when we left the hospital, and we were only advised to go and see a pediatric psychiatrist. And this pediatric psychiatrist, bless her, she could see from the get-go that she did have something other than FND. It was more likely, in her view, Sydenham's Chorea that she was suffering from. She could even tell by the neurological signs that she was presenting. So we sought advice from the Gilberg Center. Gilberg Center is not a treatment facility as such; it's more a research facility, and they do they do see children from all over Sweden, and they advise the local hospitals in how to treat pandas and PANS. And our daughter, luckily, was admitted into an IVIG study, a research study, and she was improving remarkably on the IVIG, and she also got antibiotics. And we were so happy until she relapsed. So when the IVIG stopped, she relapsed, and the first relapse, she actually had a rheumatic fever episode, and the chorea returned, and so did all the other symptoms. By the second relapse, our daughter was no longer able to walk independently, and she was put in a wheelchair. And the IVIG did work, but it didn't work all the way. It didn't actually affect her gait properly. So the Gilbert Centre luckily sent us to Dr. Elizabeth Latimer in Washington, and she diagnosed our daughter with rheumatic fever and Sydenham's chorea. And she also initiated a treatment protocol that our doctors in Sweden luckily did follow. So by the autumn of 2023, our daughter had some pulses of steroids, and it did work a little bit, but still the gait was a big issue. And in spring 2024, she had her first Retux treatment. Within 3 weeks of that treatment, we could actually see her gait improving, and steadily improving ever since. She can now walk independently. She doesn't need a wheelchair. She can run. She can be the happy child she was before she got sick. And we are so pleased to see this progression. She has also obviously increased her school attendance, and we are getting, she's improving bit by bit, and we are so, so grateful. I need to mention as well that within this time frame, she was also diagnosed with Hashimoto disease. So that's an autoimmune disease as well.
And that's the thyroid component, right?
Yes, that's right.
Thank you for sharing that.
Thank you.
Am I cutting you off, sweetheart? No, okay.
No, I guess we should just both say thank you that
Yeah,
we
thank
could
you so
present
much.
today. And
And
of course, we
I
didn't have
also
so
need
much
to,
time.
sorry, Stina.
No, go
We
ahead.
also need to really thank you, Diana, because you have been such a support, and I don't know where we would have been without PANDAS Network and your
Well,
support.
we should tell the parents, that the magic of social media, which did not exist when I see Dr. Trifoletti is here online listening to this. I'm so glad you're listening, Dr. Trifoletti. And he's suggesting that we need to have a PANDAS PANS / I need to add Sydenham
Yes.
Korea Journal to really
Yeah,
candidly discuss this, because parents have the blessing of social media now to connect with each other. And the Swedish mothers connected with me via Messenger during the pandemic, and I was very sick. So I was just laying on my bed texting, random people. I don't know if they found me, but every parent listening, and Dr. Trifoletti understands this, Dr. Cunningham understands this, that we are the only ones who are going to push this forward, because the mainstream doctors, I don't think they don't believe us. They don't know. And somehow we need to now push more clearly that
exactly.
strep,
Yes,
I'm just focusing on strep. I know there's a topic of PANS and mold and other things that are problems, but at the moment, the strep throat bacteria, it's why we've kept our nonprofit name PANDAS Network. I wanted to really see if we could hone down on strep as a bad actor, and it is. And that's, I was going to just say, parents that are listening, stick together, and then you'll find the answer, because Dr.
Mm.
Latimer really came out of the woodworks and talked to Sweden because the
Yes.
parents pushed it. And then your doctors were very gracious. And it's
Yes, exactly.
wonderful. I
Mm.
hope Dr. Cunningham is still here. Did you go away, Dr. Cunningham? She went away. Oh
No,
no.
she's
There she
here.
is. Hi, Madeline. Unmute yourself. Come back. It's on the bottom left corner of your screen. Your little red mute, you crossed out your, there you go.
Took me a minute to get to it. I had it turned off.
Dr. Cunningham, I see that Dr. Trifoletti's online here. He won't be speaking at this time, but I was just talking about you. And could you kind of explain um, in 5 seconds, I'm kidding, why a child like Amy's daughter can present with eating restriction? That's one aspect of strep. And then other children can have this profound chorea. Why is it so different, but it's from the same bacteria?
Well, it's because it's a systemic autoimmune disease, and there are pieces of rheumatic fever that are similar to lupus. Lupus is a systemic autoimmune disease, and we published, it's been in the 1990s that there was a specific antibody idiotype shared between lupus and Sjogren's and acute rheumatic fever. And there are pieces that people have found that are similar to lupus. It's, of course, rheumatic fever is not lupus. That's why it's rheumatic fever.
But the
And
children
we
have
know the infection, whereas for lupus, they suspect it's EBV, Epstein-Barr virus, but there's no complete proof for that. But here, this was why our studies in the 1990s were so important, because people didn't realize how autoimmunity developed from an infection, and that's what we worked on for a
so
long time.
so Dr. Cunningham, we were speaking briefly yesterday, and you're going to do your presentation in 5 minutes, and you can do all your slides, and then
I
we'll
hope so, if we can get it ready.
yeah, we can. And then after that, there'll be Q&A. Mommies and daddies and whomever else is listening can ask you questions after you give your longer 30-minute presentation. But for the moment, and Stina and Ulrika and Amy, if you have a question, you can ask her too. But right now, but you said to me something yesterday that was important. You said, I think doctors and I didn't understand this before when my children were very young. Doctors are not keeping up with the autoimmune aspects of strep. It's just not talked about that much because it's been rare. Although people don't like the term rare, and when it's around strep throat bacteria, it can be a rarer incidence. So how can we maybe educate doctors more about it?
I think you're doing it, and also the medical schools do try to have this in their curriculum, but the students don't ever see it. So it's as if, their neurologists, one of you were talking, that they'd only seen one case of it. And so rare diseases are important for people to talk about. You've got a support group. And in addition, doctors can try, especially pediatricians, to make themselves more aware of it, especially when we get out here and uh, make a program where it's possible for um, doctors to actually know that we're doing this, and patients go back and talk about it.
Somebody just asked online here an important question. They said, is Huntington's chorea the same as Sydenham's chorea? And or I do know one family that had genetic Huntington's. It was a neighbor of mine whose child got strep and got very profound chorea, similar to Eureka and Stina's daughter.
Well,
Um,
Huntington's is more of a genetic disease, but I do want to point out that all autoimmune diseases are related to the histocompatibility antigen complex, which is HLA. You always, if you get an organ, you have your tissue typed, and so this is about our histocompatibility. And
of histamines,
HLA,
is
right?
histamines.
GWAS in lupus, HLA was the top genes that are important in leading to lupus. It's our HLA antigens that actually they present antigen to cells, and so the B and T cells or work importantly based on this, and particularly the T cell.
So
And
that's why rituximab might work for some of the more severe cases because B cell and T cell is involved and you need to quiet it down. And then in a quieter, like a quieter case, I know it didn't feel quiet, Amy, to you, but in a case where it's just this eating restriction, like is it just a less of a dopamine hit? Like the antibodies are less intense in her daughter's case? Or we don't know.
well, they are binding to the dopamine D2 receptor, most likely because drugs like olanzapine, which can treat these types of situations, binds to the D2 receptor and helps. Haloperidol has been another one that works in addition to these, because that's all we had before we had IVIG or we had rituximab or before we had any of these drugs. They used haloperidol, which ironically is a D2 receptor blocker, as is olanzapine, which treats um, people that don't eat, that they have an eating disorder.
Now,
Uh,
haloperidol was scared. You told me about that when my son was 8. He's now 26. I had 2 kids with PANDAS audience. They're doing pretty well. My daughter has relapsed 4 times, but she's stable, thanks to medication. But haloperidol was scary to me because it's a psych med, but you're saying it's okay to use sometimes for if it
well,
diminishes.
Uh, there was one case that we had that the child was so paranoid, IVIG perfectly corrected them, but they could not go because the child refused to go, and the parents were unable to ever get it for her again.
The
So
IVIG.
he was treated with the haloperidol and is much better, but it's not a complete cure like the if you get to the underlying basis, which is the autoimmunity, and you're actually able to rectify that. It's important, and people need to realize that repeated streptococcal infections lead to these situations in the case of rheumatic fever. And so that's why children are treated sometimes until they're 18. And this is part of the American Heart Association guidelines for rheumatic fever, and particularly rheumatic heart disease, which I'll talk about. It affects your heart and valves, and if you continued having strep infections, you would lose your normal valve and have to have a
Uh,
replacement. So,
Dr. Cunningham, we'll probably have to have another webinar with you to like get deeper into this. But somebody just asked a really nice question, simple question. And then I want you to share your slides after this. Okay. Um, what is the best way if a child keeps getting strep to check to eradicate it? Should it be swabbing? Should it be a blood test? And by the way, Dr. Cunningham, you cannot get a blood test for strep in the UK anymore. They've taken ASO and DNase off the list. So we have work to do worldwide about allowing strep testing to occur a little bit more simply. But with this United States family, and they have a child with a lot of strep, how should they check for it and encourage their doctor?
it may be that the reason that the UK took it off is because it is a good test, but it's not indicative of immediate infection. It means that you had
Oh,
infection previously.
I see.
And so they may have decided that it was really just better to go in and get your throat swabbed
I
and
see.
have a culture or have a quick strep test. The quick strep test is not quite as good as the throat swab, but it's what we have, and it's what we would need to use to go
A
in.
throat swab means a culture that's
And,
48
and
hours.
remember, well, you would culture
30.
the throat when the child's sick, so that you determine whether it's strep or not. And it can also be other places besides the throat, because rectal swabs may be important. I have had cases that people have talked to me about where the rectum is very red and they have streptococcal infection in the rectal area, or may have strep in their colon. So it's very important to realize it could be somewhere else. And you can have skin infections also. That's called impetigo. But these are the different ways strep infects us.
Well, Why don't you share your slides now, and we'll get a lesson on what strep does and is, and we're going to have more time to ask. Can you talk about why other viruses seem to cause major symptoms? Oh, that's true. Once you get Sydenham's, Chorea, and or PANDAS, any other infection can trigger you. Can you just speak to that very briefly and then
I'm
share?
sorry, I was so busy and worried about showing my
Just
slides, but
somebody was asking, why does once the child has strep, Sydenham, Chorea, or PANDAS, how come they're really reacted to other things like viruses or
because their immune system actually, Dr. Frankovich and I were talking about that because she studies PANS heavily, and that strep, I think we both believe she would agree, since we just were at a meeting together this past weekend, that strep may actually start everything when they're young children. And then as they grow, they get other diseases, and some develop immunity against strep. And so they develop mycoplasma or Lyme or other diseases that um, actually appear in Lyme disease with strep. All the patients that I've ever known that had that together were the sickest of all the patients. So it's just other infections can aggravate the immune system because it's all B and T cells that are.
okay, B and C cells? People need to Google what those B and
We
C cells
respond
are.
to
So,
all infections, viral, parasitic, fungal, whatever. We respond with our immune cells, which are B and T cells, and these are adaptive. And also, I should point out that a lot of the studies now that are being done are of the uh, innate immune system, and of course, that's very important too. But it's not specific to a particular antigen. The innate immune system is non-specific, but it's very important up front before you start making antibodies. And then it continues also and can lead to more chronic disease. So all parts of the immune system are important, not just the antibodies that we've studied, because when you do research, you focus on one thing. You have,
so
but all the different parts of the immune system are important.
well, Madeline, start to share your slides, and we're going to all go, Stina, Amy, everybody, let's make our screens go off, but stand by because we'll do Q&A at the end.
Right.
And
And I'm going to go fast because I don't know if your um, um, timer goes off.
30 minutes to talk. Go for it.
Okay, thank you.
Okay. Thanks, Madeline. I'm right here if you need me.
All right. So we're talking about autoimmunity and infection, just to pinpoint the autoimmunity as we've been talking about, because it is true that most people don't think of strep infections as being autoimmune. And the infection itself isn't, but it creates a very strong immune response that in some people develop Sydenham, Chorea, the group A, other group A streptococcal sequelae like pandas. And there are some biomarkers and that we need to talk about. Have had funding through the National Heart, Lung, and Blood Institute and the National Institute of Mental Health and the American Heart Association. Many of the foundations have been so supportive. Uh, and we also have a company that offers testing for pandas and Sydenham, Chorea, and chronic diseases that go along with them. The group A streptococcal diseases you've heard much about today, so I'm not going to belabor them, with acute rheumatic fever being the major sequelae that we see most often. Acute glomerulonephritis can occur, but it's very rare, even more so than the ARF. And it comes from pharyngitis of the throat, impetigo of the skin, and so on. And so one thing that I wanted to be sure we talk about are some of the guidelines that come from the Jones criteria that's published by the American Heart Association in Circulation and Circulation Research. The major manifestations of acute rheumatic fever include the most serious carditis, the most common arthritis, and Sydenham, Chorea, which is the brain manifestation you have seen, and then erythema marginatum is a circinate rash, and you may also see subcutaneous nodules. It's important to get a positive throat culture or a rapid antigen test. In the past, elevated rising anti-streptolysin O or anti-DNase B titers. These are important laboratory findings to be confirmed if you are going to be diagnosed with rheumatic fever, because the Jones criteria require two major manifestations and one minor or one major and two minor, indicating a high probability of acute rheumatic fever. The T cells that we believe are important are Th17, Th1 that get to the lesions or promote these diseases of the heart, lung, and brain. And you can see, I don't mean lung, heart, heart and brain. The joints may be affected or the skin, and the cross-reactive antibodies that bind to the strep may be activated, and then they may become changed over time so that they become cross-reactive and recognize antigens in the brain or antigens in the heart or antigens in the joint. And the Th17s are important, and these are those cells that are present in your sinuses, in your gut, and they respond to these extracellular bacterial infections that enter in the throat and are taken up by epithelium. The sharing of these determinants by the immune system, either antibodies or T cells, cross-react with M protein or the epitope of the group A carbohydrate, N-acetyl beta-D-glucosamine. And so antigens have been discovered, cardiac myosin and laminin in the heart, lysoganglioside tubulin, and the dopamine receptors in the brain. And this cross-reactive immune response in the heart is what leads to the valve disease that's seen in acute rheumatic fever, and also the encephalitis type of disease that's seen in the brain. And these are shown here. We used human monoclonal antibodies from patients that we developed to demonstrate the binding to the valve and also to the myocardium, and that's why cardiac myosin was the first antigen that we said that the streptococci, that myosin was the link between strep and heart. And that's actually when we began studies of the strep antigens, such as the N-acetyl-glucosamine or the M protein. These antibodies, interestingly, are IgG2 primarily, and in all these cases of rheumatic fever compared to a control, bind the endothelium of the valve. These are also seen in the CSF very strongly in Sydenham, Chorea. These are, in this case, we demonstrated that it reacts with glutamac. And this is also seen in the valvulitis, but I don't have time to show this. And so the VCAM1 on endothelium is activated in rheumatic heart disease. This draws the T cells into the heart valve, and these are important in damaging the valve where T cells come in, and these activated T cells lead further to the damage of the valve. And so repeated streptococcal infections lead to rheumatic fever. You don't probably get it with the first one. You have to get the immune system going and make the cross-reactive antibody and get the T cells driven into the hearts, which you can see here, gamma interferon and IL-17A, and all four of those hearts that had the IgG2 deposition. The multi-step pathogenesis is that you have the valve, and there is eventual breakdown of collagen because, of course, it's so damaged by the streptococcal infection that collagen becomes an important antigen with anti-collagen antibodies, and the valve becomes vascularized so that every strep infection you have destroys the valve further. And the same thing for the brain. You get irritation in the brain, and so it can become chronic. And in both situations, it's important the genetics of the host, the HLA, and various cytokines that are important in driving the disease. So not only is the heart affected, but the brain, and you saw Sydenham, Chorea, with mild incoordination to very severe disruption of movements and emotional ability that's related to PANDAS or PANS, pediatric autoimmune neurologic disorder associated with strep, or pediatric acute neurologic syndrome or PANS, with compulsive disorders, obsessive-compulsive disorders, hyperactivity, and tic-like symptoms. Sydenham, Chorea is shown here.
Is 12 years old.
Well, I'll let this go on. You've seen a lot of this, but just in case someone joined it,
Yeah,
maybe
put your hands out in front of you.
Sydenham, Chorea. And I will say, I was taught by Dr. James Solomon and Dr. Edmund Beatty, who both saw this because Dr. Solomon was from
Once more.
the era of the 1940s, where he saw the wards full of children with Sydenham, Chorea, and valve disease. And it was a very tough time then when children were dying of acute rheumatic fever. And so it's not so prevalent anymore. But I believe that many of these children died and they never had children. And so a lot of the more serious genes that damage the heart are gone. And perhaps we see more Sydenham, Chorea, and PANDAS has developed to the forefront because we don't have the heart disease anymore like we did. And so this has been difficult for people to recognize. And so the antibodies in Sydenham, Chorea, they're autoantibodies that bind the caudate putamen. And this was work done by Dr. Christine Curvan and in our laboratory in Sydenham, Chorea. CSF, PANDAS, CSF all react with the basal ganglia, probably tubulin in this situation. The human monoclonal antibodies derived from Sydenham, Chorea reacted with the group A carbohydrate epitope in acetylglucosamine. We separated it out and put that epitope on BSA and used it as an antigen, and then lysoganglioside and tubulin. The important thing was that Dr. Sweeto provided cases of acute Sydenham, Chorea, and we could see in the acute case it reacted strongly with lysoganglioside. But amazingly, when they got better, it was gone. And monoclonal antibodies helped us so much from these patients. This was my, I'm not an MD, I'm a PhD, but the patient that I saw in the hospital that had Sydenham, Chorea, and their monoclonal antibodies, these are B cells that we made to last forever and make their antibodies, and they reacted with lysoganglioside. These antibodies also signal neuronal cells and bound just like anti-ganglioside antibodies to these neuronal cells. And this signaling was through calcium calmodulin dependent protein kinase 2 in the neuronal cells. And you can see this one monoclonal and all the control of the others that are here that don't react. And the isotype are basal, normal. And then in the case of the patient, we can see the acute, and then when they're well and don't have Sydenham, Chorea, convalescent. So we studied PANDAS, and they were also signaling, not to the degree as in Sydenham, Chorea, but in PANDAS cases, Sydenham, Chorea can overlap and they can have piano playing movements of their fingers and toes, but in pure PANDAS, you don't see that. Or, we don't know because we haven't done longitudinal studies. Maybe it's a process early on in childhood when this begins. So this is just the pathway of CAM kinase to making too much dopamine when it's signaled. And of course, changing and making an imbalance of dopamine in the brain of children and other patients. I've seen patients 74 that had Chorea. Transgenic expression of this monoclonal antibody in mice led to its deposit in the basal ganglia in this green area in the basal ganglia of mice that they had the gene for the antibody. And when we immunized them, then the antibody went to the brain and it actually entered dopaminergic neurons because this red is tyrosine hydroxylase that demonstrates a dopaminergic neuron, and it's the same neurons that the antibody entered. And so this is how it works in the basal ganglia. And this just shows that the sera from Chorea signals, and this is control. And that in the case of D1, which is another dopamine receptor, that in pure pandas, D1 is elevated only, but in Sydenham, Chorea, it often is a mixture. And these antibodies bind to the receptor, the D1 binds the receptor, and then makes it more sensitive to the dopamine. So, and then the D2 situation is where the D2 is pushed to make much more dopamine. So it's where you have a receptor becoming more sensitive and too much dopamine. No wonder the children are not behaving properly. This is a group of Sydenham, Chorea patients from Israel in the Ashkenazi population there, where anti-D1 was elevated and anti-2 was de-elevated. This was a study by Hilla Ben-Pazi, where we collaborated with her. And her dominant in Korea, you do see D1, because if you remember, Stina Lera's child had very high D1, but most of the time in chronic Chorea, we see D2. And Dr. Menendez actually studied these through ROC curves and showed that in Sydenham, Chorea, D2 is highly specific and is the biomarker, or at least one of the biomarkers. I shouldn't be so with just one, but is a biomarker of, and then the dopamine receptor situation, you can see here that it correlates with neuropsychiatric symptoms. And so this is just a diagram indicating what happens, that too much dopamine is produced when you have the antibodies binding the D2 receptor, and then the D1 receptors become more sensitive, and you can get both pandas-like symptoms and Chorea in the same individual. The first 50 cases of pandas had a little bit of Chorea. And I think that's because they were studying Chorea before that and had all the cases. So these antineuronal antibodies in the autoantibody panel that we offer, you can see anti-D1 is elevated, D2, the lysoganglioside and tubulin, and also the CAM kinase. And this is in the symptomatic individuals. But then after worsening episodes, it's more elevated. I think what I was showing in that last slide was what happens is when they get better, it goes down. But you had already seen that too in the Sydenham Chorea, but this is in pandas. When the antibodies, the panel goes down, then the children are better. And then the same thing for worsening. If it worsens, then the antibodies become elevated. But it doesn't mean that cytokines don't play a role, or that T cells don't play a role, because they all do. B cells are the lead to the antibodies.
Madeline, I'm just going to interrupt it. Sorry. This was the autoimmune brain panel at Molecular can be ordered to measure some of those things. And then could you explain just quickly when parents should order it, like when their kids have symptoms?
Symptoms, right? Normal children should not be tested. We're getting ready to publish
Okay,
paper with Hilla Ben-Pazi that shows that in pharyngitis, they become elevated, but only briefly, and that they disappear in 2 weeks. Whereas in Sydenham, Chorea, the antibodies just continue to go up, and the same thing for pandas in children that develop the autoimmune diseases of Sydenham, Chorea, and pandas.
Thank you.
So then it's a two-step process. You have to break the blood-brain barrier, as we did in our transgenic animal, and then the antibodies enter the neurons, as you saw there. And so Dr. Patrick Cleary and Dr. Mark Jenkins established a model where they showed that it went up. This was with Dr. Dertan Agaloo, went through the olfactory bulb up into the brain, and this was how the blood-brain barrier was broken with IL-17A, which comes from these T17 cells that respond to strep in the sinuses. It's the way it responds. It doesn't mean you don't have other T cells like Th1 and Th2, but Th17 are the ones that are there in the mucosa, and the same thing for the gut. And so I'd like to thank the many people that I've worked with over the years, including those in my laboratory, particularly Dr. Menendez, who is with me and did the final studies of the antibodies showing how you would separate the biomarkers of um, Chorea and PANDAS. That PANDAS is more D1-like and Sydenham Chorea is more D2-like, but it doesn't mean you can't have one more elevated than the other in the Sydenham Chorea or PANDAS if you have more of one than the other. And so really, PANDAS is, I wish it in a way were included in the rheumatic fever group, and then there might not have been so much arguing about the treatment with antibiotics, but the children should be treated with antibiotics. And based on what we know, and we've studied over the years Dr. Frankovich has done it, Dr. Sweeto has done it, that you have to give antibiotics for a lengthy period of time. And the American Heart Association recommends until the child is 18. So
Thank you.
thank more people, Dr. Sweeto and um, all of my group, Menendez, Zuccolo, and Curvan, and Carol Cox, who made the transgenic mice. I mean, these experiments don't take 1 year, they take, 7 years. It's a long process doing the research, which is what my business is as a PhD. And even thank Harvey Singer, who always commented he didn't like to believe in pandas, but I have a paper with him, and in Tourette's, we found the antibodies. And so they were constant because they were chronically sick. And I think that it just, D1 is very important, and the CAM. He even said that about the CAM. He thought the CAM would always be a super important thing. In my lab, Dr. Curvan, and who really was so important in this work, and Dr. Sweeto, and Dr. Chandra Menendez, who did the work recently to show very tedious work that just took years to do. And we thank her so much for providing that, because it shows the ROC curves show that they're biomarkers of these diseases. And Dr. Sweeto, because without her, she just won a Lifetime Service Award from the Alex Manful PANDAS group. So we appreciate her.
Thank you, Madeline. Hi. I'm trying to get our panelists back on. So thank you so much, Madeline. What you were describing at the end, because I don't think everybody understands all the terms you've used, and we have about 100 people who stuck with us the whole time, and we recorded this, so it's going to be circulated on Instagram and Facebook and every place else, and we're going to keep talking about this and making it more succinct, I think, because we're talking about a lot of things.
And Diana, let me say this, that I think people at the NIMH and everywhere, they do want it to be. It's just the confusion, I think, that has led to some of the disagreements. And I think we're all coming from the same place. We all want to help our children.
Yeah, I hope that's a good attitude. Thank you, Pioneer. I don't think we have to do a separate webinar just about you and your father's background, Dr. Cunningham, and interest in strep. And, this woman has carried rheumatic fever from its infancy to what it's evolved into now worldwide. And children used to die from rheumatic fever and strep throat all the time, right? It was a terrible scourge. And we've done such a good job of eradicating it because of your father and Dr. Stollerman and you. But now we're having to clean up, we want to keep reminding people that there's still this icky thing that's happening, and I'm the descendant of a great grandmother who had rheumatic fever. We're seeing 20% of the families remember grandma, grandpa, or mommy or daddy, usually great grandpa or grandma had rheumatic fever, and we're likely the descendants of that. And so your work, back to the CAM kinase, that's long. I think we need to do that on another conference, but you were referring to tubulin and CAM. I know that's in the autoimmune brain panel that you helped develop or you developed, but those are names for areas that the immune system is attacking in the brain, right? The CAM. And then somebody asked, a grandparent asked a very good question. They said, well, how come I can't just do homeopathy or naturopathy for my grandchild to get rid of this terrible reaction? And I just say, well, strep's a bad actor, you got to use antibiotics. But what do you say to that?
It's because it's bacterial. If it were viral, you would have a little more trouble. Remember, we took antiviral agents for COVID and we take them for a few other diseases that we have antivirals for, like herpes. They have the cyclovir group of drugs. But for strep, you have to be specific and take drugs that will kill strep, because if you don't, the strep will continue. And if they don't continue the antibiotics until they're 18, I mean, that may be too radical for a lot of people, but if you don't continue them, the repeated infections are going to continue to cause damage, because for people with valve disease, you have to take them until you're 18, or you will lose your valve and become very sick the rest of your life. And so it is urgent, but we don't see that in the United States very often. We do have, like last summer, they had a case of rheumatic heart disease here in Oklahoma City, one case. And so maybe every state has one case every year. And they have to be treated with penicillin. They must take it. And some people get bicillin shots. And actually, Dr. Falcini and I worked together. She was a clinician and she gave bicillin shots to children. And it did help improve the situation with pandas. It didn't cure them entirely because they were still young and, exposed to strep. But the treatment did help with the infections, and so it
And
dampened the pandas.
Dr. Cunningham, for Amy and Stina in particular, maybe you guys have questions, but with the eating, and my daughter had eating dysregulation, but not at the level of your girls. Like, how do you have a specific question, Amy? Because you never had a chance to talk to Dr. Cunningham about what could change or.
I think probably my biggest concern is she does have occasional relapses. She just told me that she had 3 days when she was in college when she was struggling to eat, which she did not share with me while it was happening. And I guess we've always used antibiotics and it's always worked. I'm very pro-vaccine. We gave her a meningitis vaccine when she was turning 18, and within 3 hours of that vaccine, she had pandas again, which we hadn't had in 3.5 years. And we didn't know how to fix it, and ultimately we didn't fix it. It took 10 days that time, and antibiotics didn't work. She didn't have a strep in her blood even, and I still to this day don't know what I should have done differently.
It's about the dopamine. You end up and trigger everything, and you get more dopamine, and it takes time for it to calm down. But the preventing the infections, some people have given antibiotics until 25 or 23. Each individual case is its own case that you would have to discuss with your doctors, and decide what you wanted to do. If you wanted to treat for, say, 30 days, just to try to be sure she got calmed down once she's had an infection, rather than stopping the antibiotic in 14 days, or some people give it only for 7 days.
The new guidelines for Sydenham's Chorea, this is kind of doubling down on what you said, Amy. The new guidelines for Sydenham's Chorea are much more well written. I should probably I'm going to send out a big email to everybody, not once, but twice after this webinar, because anyways, but so I'll attach it in the email I sent to everyone, but there's new Sydenham's Chorea guidelines where they talk more about the mental health symptoms so that doctors might pay attention to it. But what Ulrika taught me and Stina taught me uh, many times is that there's not a lot of interest anywhere in the world. That's how it feels for children or young people who are relapsing. And there's some that are relapsing mildly into their 20s and 30s, like Amy's daughter and my daughter's in her 20s. And I just, Amy does antibiotics. My daughter doesn't respond to those anymore. We have to spend $10,000 on an IVIG, and we've done it 4 times now. Uh, not at a hospital, I'll just say we just do it. And so there's not a lot of interest I can see worldwide on the continuing like lupus-like, which I don't understand. I know you talked about it, but the lupus-like autoimmune process these kids have that's lingering. Like, I guess we need to keep having meetings, Dr. Cunningham, because we need to manage their continuing relapses, not with 6 months of antibiotics. I mean, that's just not an option, I don't think. But with Humira or Ingrezza or rituximab, I don't know.
Well, I think again, it's an individual case. People have to, with their own doctor, because each person, you heard the cases here, they're all different. But yet they still, there are huge problems when a child is that sick that, drastic measures do need to be taken, which, include all the things you're talking about that they used and and your child got well because you used IVIG and she got better. At
I
least,
know, but I'm like a crazy person. I keep
but I
getting
mean,
IVIG on the black market,
you
sort of, really. But
have to think about IVIG is something that we know calms the immune system. It stimulates Tregs most likely. I don't think there's been huge amounts of studies on exactly what it does, but one of the things is that it affects the Tregs and helps them calm down, and you get someone's normal uh, IgG in your body, so that may also help right things. I mean, we don't,
um,
again,
s-
totally understand it. Yes, Diana.
somebody's saying here, we're from the UK. Hey, and other panelists, you can interrupt me anytime. Somebody from the UK and similar from the US. We are from the UK. My daughter's strep titers are constantly positive. I don't know the number. Elevation. Neurologist has finally agreed to prophylactic antibiotics, which is helping. We've been referred to a specialist in London, so we're hoping for further treatment. It's so difficult to get a diagnosis or treatment here in the UK. Access to IVIG is difficult. Insurance won't cover IVIG. How long can we use antibiotics? Our doctors are afraid to do it longer than 6 weeks. We've used Ceftonir. What would you recommend beyond Ceftonir? And my quick answer, then I want to hear your answer, Madeline, is like, I just say it's going to be recorded and everyone will have this for posterity. If the antibiotics aren't working, you've got to move on to
Yeah,
steroids or IVIG. And that's it, because we
yeah.
don't have good guidelines yet,
But for a whole group, I don't want to make any recommendation. I
right?
just say you need to discuss it with your doctor. And you've heard what worked here in these situations. And we want everyone to stay healthy and not use any kind of treatment that's going to be harmful to anyone, because that is the underlying basis of all medicine, is do no harm. And so we want,
Thank you for
I think it's just important.
correcting me.
I'm trying to say what I think Dr. Sweeto would say, because I'm not an MD, but I do feel like I was trained by MDs, and we do so much research in the human sector
So,
that it's important to just talk to your doctor. Try to think yourself how you can help yourself, and coming to support groups and seeing what has helped other people, and helping your doctor get to that education point, because not every doctor has heard of PANDAS. Some of them don't want to work on PANDAS. They don't want to see you because they're just afraid. They don't know what to do.
well,
And
I'd like to keep
yeah,
expanding the
right.
term away from PANDAS and change the PANDAS Net website to more Sydenham, Korea, and just keep
Well, they're all
pushing the
together, Diana,
conversation.
because the antibodies are together.
Well, but I was never encouraged in PANDAS Network, not by you, but other, to call this Sydenham Korea PANDAS website. And I'm seeing now that there's so much good research coming out that I'm less afraid to talk about it and share the correlations.
I know, one of them was saying that Mayo Clinic turned away their daughter, probably someone who just was worried that they didn't know what to do. But we have worked with their laboratory, so they, at least some people there do know about our antibodies and, the panel. So
Why can't a spinal tap? There's like Oxford did a paper once upon a time about the dopamine antibodies found in spinal fluid.
that's published in our,
How come we can't find, like, do doctors check for dopamine antibodies like in regular Stanford?
taking the spinal, you don't want to do that unless it's just an emergency from the CSF. We cannot even get CSF anymore. Dr. Sweeto had some after those studies that had been done in Sydenham, Korea, and PANDAS early on, and then that was all the CSF we could ever get because it's dangerous to the children unless it's going to really change anything. They're not going to do a CSF.
Can
So,
you always, when somebody has classic Sydenham chorea like Stina's daughter or Ulrika's, and there's like 5 or 6 other little kids, 4, 5, 6 years old that have been listening to this webinar. Their kids are in Wisconsin, Pennsylvania, Maryland. They have classic Sydenham chorea. If they went to their doctors at Johns Hopkins or where Washington, whatever their hospitals are, could they get a spinal fluid to see the dopamine in a spinal tap to see this?
oh, you would not want to do that, Diana, because
No?
you just take the blood and, the panel works on the blood too. We can see it in the blood really better than we can the CSF. And I don't know whether that's handling of the CSF. I mean, because see, by the time we got all our samples, it was very old, but we could find it um, from very high levels to low levels in the, not everyone, because maybe it, um, you know, was not preserved well, the spinal fluid, because it's much thinner biologic fluid than your sera. Sera is very protective of all the proteins that are in sera because it's got so many. Um, but anyway,
Somebody from
they're in spinal fluid. We know they're there, so we wouldn't, unless a child were so sick that and you didn't know what was wrong with them. If you identify strep and you see them wiggling, and have the milkmaid's grip and all the characteristic signs of chorea, then you're going to just treat them for Sydenham chorea. We know what to do, and I mean, in some cases, you may need the rituximab and the IVIG when they're so severe. But I think before, um, people thought people with Sydenham chorea, this is what physicians thought, is they just got better. That
right.
we would not, because in olden times, the thing was heart disease was going to kill your child if you had rheumatic heart disease, because this was very serious, and that was why the penicillin was so important. They're still doing studies in Africa with the treatment using the penicillin and what's the best method. Andrew Beaton has all of those studies done, and they've done Craig Sable, Dr. Sable, the two of them have been just totally devoted to understanding about penicillin treatment. But Sydenham chorea is still rare. You can have it with the valve disease. It can be together, but oftentimes it's not. And, all people that have Sydenham chorea, get an echo for your child. Be sure their valve's okay. I'm sure your doctor would, but doctors haven't seen it in so long that it becomes very
Right.
difficult.
And I'm hearing remarks here from people saying doctors just aren't seeing chorea. I mean, I've been lost, in the topic of PANS
It's
and
rare, we all admit it's a rare disease.
well, it's not rare in my world because I get
No, I know.
emails all the time.
Right,
But
absolutely. People, this is so important. What you're doing is amazing. And in fact, I had even invited two program officers I know from NIH if they wanted to come today. I don't know that they're here, but I think it's important for everyone to realize what's going on and that, we're trying to do our best. We may say some things that aren't exactly right, or we might not do things that are exactly right, but ultimately, we're trying to make an effort to educate people so that when they do see it, again, they're going to work with that individual person to try to
so
help.
I'm going to stop you. There's somebody from Bulgaria. It corresponds to what you're talking about. There's somebody in Bulgaria who's a doctor here saying, counting me, there's only, we have several patients, over a dozen, with many symptoms, and the treatment in Bulgaria is only penicillin. And another person here in the
That's
U.S.
all we had times ago. That's all we had. That's why they had the um, long-acting penicillin where they gave it as an adjuvant in your butt.
Yeah, a shot. And then, right. And then somebody here is asking, so Sydenham's chorea and PANDAS and PANS are still considered separate diagnoses, correct? And
Yeah,
I'm saying
and they have,
yes, but
yeah,
we think
yeah.
perhaps it's we
Because
need to
PANDAS
change.
is more D1 and more the tics and OCD, and the Chorea is more movement, strong movements, but they
Okay.
still alternate. You can have more D1 or D2 at any one time, but
And then
ultimately all the patients that we saw, the top antigen was D2 in the Sydenham Chorea, but you
and
saw
it's
D1 still there. Whereas in strict PANDAS, without any choreiform movement at all, you don't see much D2. It's a very normal level. Because
except that I think, like, even in Amy's daughter's case, and what I tried to point out in my first slides is that I think most PANDAS cases have a neurological component that's just a little bit, it's
yes,
more quiet. Somebody asked too, my favorite topic, do you think, Dr. Cunningham, that there's stress on the microbiome of the world, and we have more virulent strep strains causing some of this, and or is COVID causing some of this? And could you speak to what you've taught me, like the evolution, bacteria and viruses keep evolving and it's a constant battle, right?
but there are two things. One is that children get their antibody levels really high normally by the time they're 15. Then here comes COVID, and we all mask. And so the children aren't exposed to as much strep because you might be surprised they're exposed to strep, but you don't even know. And they're building, because of just colonization, they build their immune system. And by the time they're 15, they have antibodies that may protect them, and then they may go on and have PANS, and you won't see strep in them anymore because they are protecting themselves. They're immune. Um, but so that was one piece, that maybe in COVID, some of the children, and we're seeing a little more strep or Sydenham chorea are very more serious things. If we are, that COVID masking could have prevented some of this development in our children, where they got immune by the time they were 15. But they're still, now that they're unmasked, they're going to see strep and they're going to become immune, because this is well known by the time they're grown. And this should protect them against strep. But in some children, there can be immunodeficiencies that they have that are important, and it may not just be the antibodies. It might be a deficiency in complement, or it might be a deficiency in a particular cytokine, or it might be their
Yeah.
enzymes are deficient. So we see this in some children, and you do know that the younger children are immunodeficient anyway until they build their immune response to
That they're
carbohydrates. To
So babies aren't born with knowing how to handle strep. They acquire the talent to counteract strep over time.
That's a good way, right, to say it.
Over
Uh,
time. What
um, but
about
but we were, but I think also, over time. I've forgotten your question that you asked, because I started out then talking about the masking.
just M1 UK? Is it
Right.
causing
So
the problem?
the
Strep
invasive
strains?
strep is important because it has increased worldwide, at least maybe it's double. I haven't done the math, but all of those are very, strep is increased in people.
Right. If people can watch, one of my passions, if I was like 50, I would probably go back to school and become an epidemiologist, but I don't know. You can't do it right
We
now.
need them in pandas. That's something that they said about one of the grants I submitted. I need an epidemiologist. And the reason is because we need to do these longitudinal studies, and we need to start and see the strep infection and see how it evolves, and whether eventually it goes away, and
So,
as they get immune, because we can study different age children and try to see how they evolve in this disease and how it
So
develops into PANS.
something that's blowing up here in the email chat, and we're going to close in 5 minutes or so, everybody. 5, 10 minutes.
At least I wasn't too long, thank goodness.
No, you're great. If everyone could be here probably all afternoon with you, Dr. Cunningham. Tonsillectomy and adenoidectomy, there's several questions about it. And I know that Amy, Stina, and Ulrika, you did tonsillectomies and adenoidectomies. No, you didn't, Amy? So I didn't do it on my daughter. I did it on my son. My son's never relapsed. Stina and Ulrika did do tonsillectomy and adenoidectomy, and it used to be something people did a lot for strep because of the awareness about death from rheumatic fever. Do you feel like it helped you guys, this tonsillectomy and adenoidectomy, Stina and Ulrika?
Well, what I could say, we did that just before we started with the IVIG, and my daughter was in very poor state at the moment. And she did become better, but it's difficult to say exactly what did what. I think another thing that I would like to mention as well, that I forgot to mention in my presentation, was that I think a lot of the problems we had came from the teeth as well, like infection in the
Thank you.
mouth.
That's right. That's
I
your
think that's
unique
also
Swedish
something that we
thing.
had done. We did the tonsillectomy, but also we've been working with a dentist in Sweden, both Ulrika and myself.
Yes.
And I think that has been
tooth.
really helpful.
A bad tooth is just as good as anything to cause a flare.
Say that again, Dr.
I mean,
A bad tooth
But
is
a bad tooth is just as good as anything to cause a flare.
yeah.
and
And I think that's how it all started for us. So when we got the teeth in order, everything else sorted out as well.
Yeah.
A
So
lot of
we've had
infection.
those issues as well. And my answer to the tonsillectomy is basically the same as yours, Stina. It's difficult to tease out what is what because we started with another type of treatment as well, but we haven't had any relapses since.
Mhm.
And I believe
And yes, and we have worked with the same excellent dentist, Dr. Helena Anju in
somebody's
Sweden.
asking me, could you clarify this dentiogenesis imperfecta and what does she do to clean their teeth since their teeth are and the gums have a problem?
I guess what we could say, Ulrika, is like what she
Yeah.
wants us to do is that the children should be treated like other children with heart diseases. They should be
Exactly.
Thank
Yeah.
protected in the same way.
Yeah.
That's what she say. So you need to make sure that it's mouth, and we are rinsing with I don't know what's it called in English, but to kill
It's a
bacteria in the
solution.
mouth. Yeah.
Yes.
And it's like it should be the same, like the dentist should treat the child as another child with heart disease.
So she's very clear on the fact that you do need to have prophylactic antibiotics before you do any dental treatments as well, because that's what she does with the children with heart disease to protect them from further infections and
So
flares.
the mouthwash you use, like my son's doctor was a heart specialist, although my son didn't have heart issues, and he said use saline solution to wash, salt and water dilution. What did you use? Like an antibiotic kind of mouthwash?
Antibacterial
Antibacterial.
rinse or something like that
Yeah.
that we do, which is fairly strong. So I mean, it's not
Yes.
bad, but we do it. I still do it. Also, when my daughter was worse, she had problem every time she had a loose tooth. It started with like the teeth are like caps, and she got bacteria inside, and that's how it all started from the beginning. And she had that twice, and then after this we have had all the like when all the loose teeth disappeared, like the last few, we actually went to the dentist and we pulled them out, and then she was fine. And then the infection, like her gums and everything, got better after that. And then we also, of course, then have been using antibiotics a few days before treatment and a few days after. So we're always prepared. And we have gone to the dentist more frequently to clean the teeth and to make sure that the mouth is fine.
Yes.
And somebody here is saying, I'm an adult and I had my tonsils and adenoids out, but I still relapse. And I think that's what we're talking about, Dr. Cunningham. It's an autoimmune condition. So these adults probably deserve a better autoimmune treatment than they're getting.
in the case of diseases like PANDAS and as the children grow older, I mean, they become teenagers and the chronic disease becomes like POTS can happen, and the antibodies, like the dopamine receptor antibodies, are against an antigen called a GPCR receptor. These are the dopamine receptors. And then as it moves to POTS, they become against like the beta receptor in your heart, because some develop tachycardia. I'm not saying they definitely come from that, but it's possible that these morph into that the immune system, it's called epitope spreading, where the antibodies to the GPCR receptors become to other antigens too, in addition to the dopamine receptors. It just spreads to other organs, and you have tachycardia, and then you also can have dizziness, because these are some of the alpha receptor and beta receptor um, antigens that are like the dopamine receptor, but they're on your vascular tissue, and so you end up sick with POTS. And this disables children. I mean, they end up and are not able to function and stay in the bed for, I've talked to people that their children were in the bed for years. It's a very sad situation. So you've listened to Diana talk about how she stays on top of it with her teenage and grown children. They're in their 20s because even in college they have relapsed. And so she quickly gets treatment to them, and then they become better and go back to school and are healthy. But
The
it's
other, the the work that I want us to continue to talk about is how strep can attack. I mean, this isn't theoretical. Like, I've known you many years, Dr. Cunningham. So I used to think it was like, oh yeah, it hits their brain. Okay, whatever. But now that I'm looking in microscopes with you and Jatan occasionally, I'm like, oh no, it's like literally on the neurons. It's really some crap on their neurons that needs to be removed. So people need to treat quickly and not take 5 years to do
huge
it.
problem. I mean, basically the antibodies you saw in the transgenic animal, that was like in being in a human. The gene was implanted in the mice, and so that antibody went straight into the dopaminergic neurons.
That's an actual
It was,
physical
I mean,
neuron in your
yeah,
brain.
to me it was just amazing, and you just can't know how hard it was to get all that together from the brain. I mean, it took quite a lot of looking to find one, where you could see all that, and this was the substantia nigra and ventral integumental area, which is right there in the basal ganglia. So
Um, there's so many questions and I can't answer them all right now, but I'm going to ask you one last one that you might not know. It's easy one. Low dose immunotherapy for strep. Have you ever heard of that? It's a highly diluted bacterial antigen to retrain the immune system, and it helps people not have sore throats. Have you ever heard of LDI for strep? No, we haven't heard of that, so we don't know.
I don't know. I'd have to read the papers on it. I haven't heard of it. I'm
Well,
not sure whether they're trying to immunize with it.
Amy, we can see your face while you're walking. You might want to turn it off.
But
Um,
anyway, I mean, we need to read up on it and see what. But again, with strep infections, you can't cure them with something like that. You have to take antibiotics. That's the final. There is no. It's like there is no collecting $200 and you can't pass go. You have your antibiotic.
well, thank you, Dr. Cunningham. I think that's a good way to end this webinar. You have to have your antibiotics, and we have to teach our doctors about this disease model. And I will do a better job of explaining your research and Sydenham's Chorea on our website.
It's a bacteria, not a virus. I have seen it
Bacteria.
listed. I would talk to people, and then they would write the article and say virus, and that's just not correct. It's a bacteria, But, you know, it is hard because people they just hear about microbes. And, you know, many think that everything's a virus, but this is a bacteria. And you have to use antibiotics to cure it, or it could kill you if you got sepsis. That's what killed Jim Henson was strep, group A strep.
Oh, was it really?
He waited too long.
And we do have more virulent strep out there. People can look at their public health websites and the Center for Disease Control and just kind of keep an eye on it. And we're going to try to keep an eye on it too at PANDAS Network. And we'll do more webinars. And thank you so much, Madeline. You're a movie star.
You all are the superstars. I really respect everything you've been through and what you've done to save your children. It's amazing.
Thank
Thank
you.
you so much.
What a
Thank you.
wonderful world to know each other. So
Oh,
love to everybody, and we'll meet again.
yes.
Mm.
Thank
You all
you.
have a wonderful.
Take care, everyone. Thank you.
Thank
Yes.
you.
So great to
Yeah.
see you. Bye-bye.
Yeah,
Bye-bye.
great to see
Bye-bye.
you.
Bye-bye.
Thank you. Bye.